Good morning, everyone, and welcome to MSA Spark. We're so excited for you to be joining us today. I am Casey, Mission MSA's Community Engagement Manager.
Oh, and I'm Lauren, the Patient Support Service Manager. Our goal today is to energize, empower, and ignite hope within the MSA community.
And we have an amazing lineup of speakers for you today. But first, to officially kick us off, please join us in welcoming Joe Lindahl, Mission MSA's CEO.
I'm Joe Lindahl, CEO. Hi, I'm Joe Lindahl, CEO of Mission MSA, and I just wanted to say welcome to MSA Spark. We are really excited about this new virtual educational offering, and we hope you'll find it engaging and useful as we go through these sessions together. Thank you to everyone who has completed our surveys. We really rely on our community's feedback to deliver content that is valuable and useful for you all. So thank you for your engagement and support. We are looking forward to providing more education and resources for the remainder of 2025. But welcome to MSA Spark. Have a great virtual conference, and I'll see you in MSA Connect.
Okay, so thank you, Joe. Now let's dive into our first session, Mind Matters, Energizing Mental Health for Patients and Care Partners.
Mental health is such a vital topic, and we're thrilled to welcome Sarah and David, who will share valuable strategies and insights.
Please note that our live Q&A will follow this session, so please ask any questions you'd like answered in the Q&A function. Now over to Sarah and David.
Hello and welcome to Mind Matters, Energizing Mental Health for Patients and Care Partners. My name is David Gonzalez. I am a clinical neuropsychologist working in Chicago at Rush University Medical Center in our kind of Parkinson's and MSA clinic over here.
And I'm Sarah Mitchell-Chen. I'm a licensed clinical social worker at Rush working with Dr. Gonzalez, and it's a pleasure to be with everyone this morning.
Yes, it is. And today we will be talking about a number of topics, but we'll be starting off with multiple system atrophy and discussing both a brief introduction of what it is that happens with MSA in the brain, and then how that can relate to mood, both for individuals living with the diagnosis and their family members. And then we'll jump into how to manage stress and develop resilience, and in particular zoom into social connection as a potent way to support health and well-being. But to start with MSA and the brain, MSA and kind of what it is, it's a progressive neurodegenerative condition, meaning that we see different brain regions that are impacted, with that impact increasing over time. And the regions that are primarily impacted are those that are related to movement and what's called the autonomic system, which essentially means that it's in charge of different automatic functions, sort of the brain's thermostat, things that are kind of on autopilot. So things like our blood pressure, or response to heat and sweating, or salivation, or kind of need to use the restroom and sensation of that. MSA can be divided into two parts, or kind of two types that are sort of chunked based on the predominant movement changes that occur. So one type is Parkinsonian, where we have symptoms that are similar to Parkinson's. So there can be slowness of movement, a rigidity, or a tremor at rest. Whereas others can have what's called a cerebellar type, the cerebellum just being a part of the brain that helps with motor coordination. So we can see in this type what's called ataxia, or difficulties with coordinated movement, and that being somewhat irregular or jerky in some cases. Overall, MSA is a relatively rare condition, impacting anywhere from kind of 2 to 4 individuals out of every 100,000 folks. And on the right over here, we just have an image demonstrating some of the regions of the brain that are predominantly impacted in MSA. So even though we think about MSA as a condition impacting movement and autonomic functions, mental health is a significant concern in MSA. Now, as we go into some of the most common concerns, you'll notice a wide range of percentages, and that's because since MSA is relatively rare, a lot of the studies that have been done are relatively small. And when we have small studies, there can be less reliability in the estimate, but also big differences in the types of people that are included in that study. And we've seen, for example, with depression, that individuals who live longer with MSA or who have more severe symptoms tend to have more depression. So if you have a study that has individuals with later disease or more severe symptoms, you may have a higher estimate than another disease that has a sample of people kind of earlier on. So with that caveat in mind, we do know that depression is a meaningful component and a common experience for people living with MSA. About half of folks may have some meaningful depression. Even though these studies, we see a wide range from a minority of individuals to up to 4/5 of folks. We also see anxiety as a meaningful experience. Anywhere from 1/4 to 1/3 of individuals with MSA may have meaningful anxiety. And that can manifest as worries, kind of thinking over things in daily life and just thinking about different experiences and activities that you have to do. But it may be even more severe anxiety, like panic in some cases, having panic attacks that come up. We also see apathy as another significant experience occurring in a little less than half of individuals with MSA. And apathy typically refers to a loss or lack of motivation and sometimes kind of a blunting of emotional experience. Apathy can sometimes be difficult to distinguish from depression, in particular for individuals kind of looking from the outside. So family members may look at someone with apathy and say, oh, they're depressed because they're not doing anything or they've withdrawn from conversation or activities. So one meaningful or one easy way to help distinguish between depression and apathy is that, typically with apathy, there is kind of a diminution of emotions to where they're less strong, they have less intensity. And so that is across the board. So there may be kind of less sadness that people experience, also less joy and positive experiences. But there also may be kind of less anger, less worries in general. So just across the board emotions may be attenuated. Although not necessarily for everyone with apathy. Sometimes apathy may be just a lack of motivation. So lack of drive to want to get things going or start projects, or a lack of initiative in actually making steps towards completing things. Whereas with depression, even though there may be a loss of positive mood that goes along with depression, a lack of joy, some people state like instead of living a life in color, they're living a life in black and white. But with depression, there's often then an excess of sadness, a lot of sadness that people experience. It doesn't necessarily mean crying, but there is meaningful negative affect and mood. But there are also other symptoms that go along with depression too. There's fatigue that goes along with it, changes in sleep, changes in appetite and weight, changes in individuals' movement as well. Some people may feel a sort of a restlessness in wanting to do more things, or some people may actually feel kind of a reduction in movement or slowness. So sometimes there can be overlap between depression and other MSA symptoms. Depression, there may also be kind of negative thoughts about oneself or the world. I'm not good enough, horrible things will happen, kind of giving more weight to the negative instead of equal weighting of the negative and other emotions, such as positive things in our lives. But in addition to depression and apathy and anxiety, there can also be changes in sleep. One of the most common concerns is what we call REM dream or REM dream enactment disorder, or REM sleep behavior disorder, where people act out their dreams. But there may also be the restfulness of sleep may be changed, that sleep may be less restful, or individuals may experience kind of difficulties maintaining sleep, kind of waking up at night. Sometimes that's even related to some of those same autonomic symptoms, to where individuals may need to feel that they need to use the restroom at night, and that interferes with them maintaining sleep. But beyond just emotion, there can also be changes in our thinking abilities, with so-called cognition. Before, we used to think that cognition was not impacted in MSA, although our understanding has changed over the years. And we actually know that up to 44% of individuals with MSA may actually have some changes in cognition. When it does happen, it tends to be changes in attention, so difficulties with focus or multitasking, or perhaps even taking longer to process through new things. When memory is impacted, it tends to be either taking longer to learn new things and kind of track new information, or needing more reminders to pull things out. So those are the types of attention and memory concerns that may happen when individuals do notice cognition impacted. But as a general rule, it is less severe than what we see in Parkinson's, or certainly less than what we see in some of the other Parkinson's-like conditions, such as progressive supranuclear palsy, called PSP, or cortical basal syndrome and degeneration, also called CBD. So we see kind of certainly less severe impairment in MSA. But individuals with the diagnosis are not the only ones impacted. We also see loved ones involved. In particular, care partners of people with the MSA diagnosis note mild to moderate strain related to being involved in care, and a general kind of increase in anxiety. And while this strain and anxiety are meaningful, the strain and anxiety seem to be less than what we see with some of these other conditions that I mentioned, like PSP or CBD. Some of what contributes to this strain is related to the safety of the individual living with MSA. So because movement and autonomic changes are the most common symptoms, that's some of the most common concerns and contributors to strain, trying to monitor some of these things and manage some of these symptoms. But interestingly, some studies have shown that some of these less common changes, such as changes in communication, swallowing, and speech, can be kind of fundamentally frustrating, or kind of change kind of the tone of the relationship and be a meaningful theme of strain and concern. But other themes are not just the individual with the diagnosis, but also kind of these care partners and managing one's own health while living with someone with the diagnosis, and being able to navigate kind of home care services and ensuring that those are available and appropriate. And we also see disparities in care partner burden. We see that despite working with an individual with the same kind of MSA severity, women who are care partners tend to disproportionately have greater kind of care strain relative to men who are care partners with MSA. So we've talked about stress, but now we should jump into then what it is and how to manage it.
Thanks, David. So, what is stress? According to the World Health Organization, it's a state of worry or tension caused by difficult situations. And it's a natural human response to these situations that prompt us to address the challenges. So we often think about this in a few different ways. We can think about it as being too much too fast, and that we don't have, without the reserves to kind of adjust to what's coming with each of these new situations. And this is all experienced so different. We all experience strain and stress so differently. And so we all respond to it a little bit differently. And that's also very normal. So you may find that you are in a situation and you roll with it, and others around you might find that same situation a little bit more stressful. And vice versa, you might find a situation a little bit more stressful, and others around you seem to be rolling with it. And that's partially the way that we each respond to stress differently and our perceived sense of what is stressful to us. And so, some of the effects that stress can have on us, there could be physical effects of stress, which might be headaches, upset stomach. We might notice emotional symptoms like anxiety, irritability, or moodiness. There also can be some cognitive symptoms like difficulty concentrating or difficulty with your memory. You might feel like I was just in a conversation and I have no idea what the takeaway was, what we talked about. There also might be behavioral symptoms. And we might notice this as shying away from some of the things that we know are good or part of our regular routine, like exercise or eating a well-balanced diet. When we're more stressed, we might grab for some of those easier foods or grab for some substances that might help us kind of blunt some of those mood symptoms that come along with that. And these are clues that maybe the stress is impacting us and that we might want to think about ways that we can kind of cope with the stress. And we'll talk about that in a second. But as we think about stress in light of people living with MSA and their care partners, we want to think about stress as being something that's normal. And we can have, for someone living with MSA, any type of stressful situation, positive or maybe a little bit more negative, can have an impact on our symptoms. So we might notice our symptoms are a little bit more pronounced, whether we are looking forward to attending a family outing or an upcoming, activity that you're going to for one of your grandchildren. We also may notice symptoms are more prominent if we have an upcoming doctor's appointment. That both of these things can have an impact on symptoms, and recognizing that and holding them in mind that, symptoms can be more pronounced in these situations. And as we think about how we manage stress or cope with stress, and also as we move through those situations, that our symptoms may improve or kind of go back to what our baseline normal day-to-day symptom looks like. For care partners, stress can also have an impact on your sense of caregiver strain. And that caregiver strain can have it, impacts both your physical and emotional well-being. So recognizing that your loved one does as well as they do because you as a care partner are taking care of yourself. It's like that analogy when you're on the airline and they give the safety briefing and they tell everyone, first you need to put on your own life vest or your air mask first before you help anybody else with their mask next to you. So as a care partner, recognizing you need to try to help prioritize yourself. It's easier said than done. I hear that all day from so many care partners that this is really a struggle, but recognizing that as you take care of yourself, as you prioritize your needs, you're also allows you to be able to take care of those around you. And so one of the strategies that we can use for taking care of ourselves is self-care. You've probably heard a lot about this word. It's been quite a buzzword in the past several years. For the purposes of this presentation, we think about how you are taking care and prioritizing your own needs. your need for rest, your need for exercise, your need for meaning and purpose, social connection. So some examples of what self-care might look like: it may be prioritizing your routine medical appointments. For people living with MSA, you may have a slew of specialists, kind of depending on what your prominent symptoms are or most bothersome symptoms are. And it might feel like going to the doctor is a full-time job. I hear that often from patients. But we might be, skipping some of those routine tests, or skipping getting our vaccines, skipping seeing the dentist because it's one more thing that we have to do and we're so tired of going to the doctor. Or as a care partner, you may be foregoing your own routine medical care in order to make sure that your loved one is getting the care that they need. It might feel hard to leave your loved one home in order to go to an appointment because you don't feel comfortable leaving them home alone. So thinking about how we're prioritizing that, thinking about how we're prioritizing eating healthy, getting a well-balanced diet, staying hydrated, some things that might feel very basic as I sit here describing them to you. These all contribute to kind of our overall well-being and our perceived sense of stress. So taking care of ourselves is such a high priority. Another thing that can contribute to our sense of stress is that there can be uncertainty about thinking about the future. And that can be really scary and unsettling for people, and may be another source of stress that we can help address with anticipatory guidance. So anticipatory guidance can help reduce this sense of perceived uncertainty about the future by providing an idea of what we might expect. We don't have a crystal ball. No one can say exactly what your experience with MSA may look like. We think about it more as kind of signposts. What might we expect along the way? And when might we expect some of those things? None of this is set in stone, and no one is making predictions, but based on how you're doing at this point, what might be coming down the road? How can we begin to anticipate some of that and maybe put some plans in place now that may ease that, and so it's not such an abrupt change in the future. It can also help us identify and address potential issues. Again, like I was noting, as we start to think about things now, maybe we can help address some of those things a little bit earlier. And it allows us to make more informed decisions about the future. And so no one wants to have these conversations. They can feel really uncomfortable, and we can often avoid them. But being willing to have these uncomfortable conversations is a gift that we can give one another. A care partner may have lots of questions or may not know what their loved one wants. And if you, as someone living with MSA, can start to share what your wishes and preferences are for care, what does quality of life look like for you? Where do you find meaning and purpose? Are there certain medical treatments that you would or wouldn't want? That sharing those with your loved ones allows them down the road to be able to help honor those wishes and preferences that you have, and can alleviate some of their future stress or perceived stress in those situations. One way to help with some of that anticipatory guidance, we can think about advanced care planning. And these discussions can be a sense of comfort for people living with neurodegenerative diseases and their care partners. Like I mentioned, there's a tendency to put these off because they can feel scary or uncomfortable, but they can be a tool to offer a sense of control and can be helpful to alleviate some of those symptoms of anxiety. We certainly, like I mentioned, we don't know what the future may look like, but if we're able to begin to talk about some of the things that are important to us, it does allow us and allow those around us to make sure that that is kind of our guiding light. And by that, it encourages shared decision making. So it creates a space for some of these difficult conversations. And there is support having these difficult conversations. There are palliative care providers that can help you think through some of these questions. That's a specialist that you could get a referral from your neurologist or your primary care doctor. But you also may be able to carve out some time at your next neurology appointment to say, this is something that's important to us. We want to begin to have these conversations. You can pace it at kind of how the interval, how much you can tolerate, what you're interested in. So you're not going to get like all or nothing. You can say, here's what we're starting to think about, what might be important, what might be a helpful place for us to start. The Conversation Project is a really wonderful resource that can also provide some prompts and give you ideas of where to start. Additionally, we're going to think about how you can build some resilience. And so resilience is this idea of a process of adapting well in the face of the adversity, trauma, tragedy, or threats of like significant sources of stress. And so it is something that can be built and can expand over time. We can learn how to build resilience. And some of the things that can contribute to how well we adjust to adversity include the ways in which individuals view and engage with the world, and the availability and the quality of their social connections, social resources, especially and specifically coping strategies. So, like I was mentioning, research demonstrates that we can build these coping strategies, that we can learn new ways to adapt and build resilience through a practice that can be cultivated over time. So this is something that maybe you decide you want to commit to work towards to maybe build a little bit more resilience. And so, this idea of building resilience, it takes some work and practice. And it can be uncomfortable. It often is uncomfortable, but it can result in some, pretty significant personal growth. You might surprise yourself. It can be a scaffolding that you can build to kind of help support you and your loved ones when you encounter difficult times. So, as you build these skills, as you learn more about resilience and strategies that work specifically for you, and we have some resources in the next coming slides that, if you encounter another stressful situation or a new symptom or a symptom changes, or you as a care partner encounter something new that kind of falls to you to figure out how to manage, that as we've built resiliency, it will still take time to adjust, but that adjustment may be a smoother. You may ease into that a little bit more quickly. And you may notice that these strategies, this work that you've done to build resilience is beneficial for you. And so this idea of, what are some of the components for building resilience? It's fostering wellness, so taking care of your health, practicing mindfulness, avoiding some of those negative outlets, maybe negative habits such as substance use. It can be finding purpose, and that can look a whole lot of different ways, but having outlets to maybe feel like you're being productive, that you are able to maybe set a goal and slowly move towards that goal, but discover that there is, we often can feel this sense of stuckness, and there can be, especially as symptoms change in MSA, some of those things that we might have previously gone to as being sources of meaning and purpose or support, those may have to shift along the way. And we might start to think about how you set a new goal. How do you find a new activity or something new to engage in that won't replace that past activity, but may supplement, so that there's something new that you're learning or growing or developing? We talk about embracing healthy thinking, and this might come in several different ways. And there's lots of supports out there to help this. So maybe it's joining a support group where you have an outlet. Maybe it's connecting with an individual therapist or keeping a daily journal. Um, keeping things in perspective can be really helpful. And then building connections. And Dr. Gonzalez is going to speak more to this building connections idea. So I'm not going to spend a lot of time on that now. But as we think about, where can you learn more about managing stress and fostering resilience? There's lots of websites out there. These are a few. The WHO, the World Health Organization, has an extensive workbook that you can go through, download, and review, as do these other resources. And we'll make sure that Mission MSA is able to share these with you. Another thing that can be really helpful for folks is exploring mindfulness and meditation. And so it might be something like guided meditation or progressive muscle relaxation. There's all kinds of different ways to connect, to draw yourself out of your mind and into your body, to ground yourself. Some of them can be as simple as different breathing exercises. This diagram on the right illustrates 4 square breathing, but it can also be this sense of exploring what's in your environment. So the 5, 4, 3, 2, 1, 5 things you can see, 4 things that you can hear, 3 things that you can feel, 2 things you can taste, 1 thing that you can smell. I might have gotten what goes with which number incorrect. You can easily look that up online, but it's this idea of kind of connecting us to in the present moment to what's going on. And there are apps that you can use that offer guided meditations, relaxation, even if you have trouble kind of quieting your mind at night. Some of them have things that are called sleep stories, which are calm, quiet, soothing, and you can listen to them as you're trying to fall asleep and can help people so that you're, again, drawn out of your mind and maybe some of those racing thoughts and can concentrate on something that will hopefully ease you to sleep. So these are wonderful resources, and we'll turn it over to Dr. Gonzalez as he talks about fostering connection.
Thank you, Sarah. So yes, diving into connection as just a potent way of building resilience. In order to talk about that, we first need to talk about the context of our country, which is that there's really been an epidemic of loneliness and isolation, so much so that the Surgeon General made it a priority the year prior. And so as we talk about social connection and the lack thereof, it's worth distinguishing some of these concepts and discussing definitions. So when we talk about isolation, that's more of the kind of quantification of connection, kind of how many people is one connecting with or seeing or not seeing in a given time period. Whereas loneliness is more of a feeling of a lack of quality as opposed to a lack of quantity. And so in the connections that one has. And while they certainly are related, if there are less people that you're seeing, you're going to feel like there are less social needs that are met. They are not the same. Individuals, first off, may experience a sense of strengthening in solitude and being alone that allows them to recharge, in particular in kind of natural environments or a park. Whereas individuals may also not have any isolation. They may be surrounded by others, but if they don't feel like there's a meaningful connection with those that are around them, they may feel a sense of loneliness, that they're not able to feel fully connected or they don't have their social needs met. So they're not necessarily one and the same. And there are different kinds of loneliness too, a sense of kind of broad community that you feel connected to, like a more kind of emotional confidant or someone close, like a husband or wife or spouse that you feel close to. that you can really confide in, or a kind of a close group of friends that you can rely on for things. So there's different types of loneliness and connection, and it really is a continuum. It's not just you're lonely or you're not, you're isolated or you're not. There can be sometimes restrictions in our connections, and it also kind of fluctuates over time too. There are periods where we have more or less connection. So with this in mind, and kind of the reason why we're talking about it and why it's important to foster is that loneliness and isolation have been increasing in prominence, which is a part of why the Surgeon General made it a priority. I mean, this graph just kind of shows decreases in companionship, engagement with family and friends, increases in isolation. And almost half of Americans report experiencing some loneliness, whether it is kind of acute or in a short time period or more chronic over a longer period. About half of Americans were reporting kind of 3 or less friends that they connect with in 2021, whereas that was only 27% of Americans back in 1990. And we also see an increase in single person households up to a third of individuals in our country, whereas that was about 13% also about 30 years ago. So, this is changing for a reason. There are a number of factors, both at the individual level, but also at a community and society level, as well as kind of that intersection between ourselves and others and relationships. All of these things can influence social connection. So there's no one cause that we can point to for why it is that we're seeing these changes over time. But it is important because connection is adaptive. We are social creatures. Even though each of us as individuals has different social needs, some of us need and thrive with connection and others, whereas others kind of don't necessarily need as much. But generally, as humans, we do rely on others to a degree, whether they are someone who's delivering our Amazon package and we don't see them, but we're embedded in social networks in our society, and it's adaptive to have those connections. And so our bodies have been designed to then send us signals whenever there's a lack of connection, whenever we're isolated or lonely, to where there's this sense of, I want to approach others. So there are kind of changes in our thinking and our emotions that kind of make us want to be more connected, that sense of loneliness. But there can also be some changes in trust. The more isolated and lonely people are, we actually start to feel a little bit more distrustful of others, because when one is isolated, we're at a higher risk of danger, in particular in our historic environment, if we weren't protected by others. So there's this increased kind of threat monitoring and kind of vigilance, and that can lead to some distrust and being uncertain about others. So there's an interesting kind of push and pull that can go along with this. There can also be changes that we see that go along with our body, because when we're trying to be more vigilant of any threats in our environment, there's actually kind of changes in our stress response system that we see. There are these inflammatory hormones and these stress markers that are built up that can have downstream effects in the body and the brain. So we see changes kind of in our biology and our psychology and what we do that ultimately impact our health. And the health effects are meaningful. Social connection, having meaningful connection, increases the odds of living by 50%. Another way of saying that is that being socially disconnected increases the likelihood of death over a period. The overall health effect on our lifespan and kind of premature mortality is similar to smoking almost a half pack of cigarettes a day. If we kind of look at this graph, lacking social connection is within that same range and kind of same health impact on our longevity and mortality. Along with that, it increases a whole host of other health conditions: cardiovascular disease, diabetes, hypertension, our susceptibility to infectious disease, things like COVID or the cold, increases the risk of cognitive dysfunction. Individuals who are lonelier have more changes in thinking over time, a faster rate of memory decline. If we follow people over a long enough period, there can be about a 50% increase in the risk of dementia for those who are lonely compared to those who are not lonely. There's double the risk of depression, double the odds of suicide that go along with those who are lonely versus those who are not. So it has a huge impact on our health. This just visualizes kind of, since we talked about movement and thinking as being a part of MSA for some people, those who are lonely, which is on this left graph and the darker line, we actually see a faster rate of motor decline compared to those who are not lonely. Their motor abilities stay more stable over time. Likewise, on the right, we see those who are lonely, this yellow line, an increased risk of dementia when followed over time compared to those who are not lonely with that blue line, regardless of whether they have genetic risk, which is what this upper and lower graph are splitting the people by. So how do we then build connection? There are a number of approaches at a societal level, at institutional levels, things like Mission MSA and some of our programs certainly help build connection and community. But at an individual level, there are certainly things that we can do in kind of setting a connection plan. What I often recommend for people to do is first strengthen the relationships that you do have. We all have people that we know. It's like, oh, I really need to reach out to cousin Joe and see how he's doing. Or, oh my gosh, Jane from high school reached out to me about the reunion and I just haven't emailed her and it's been over a month now. Maybe it's too late. Maybe I just won't respond to her. You can reach out to folks. So really strengthen the relationships that you have as a starting off point. Send that email. Prioritize it, just in the same way that we need to schedule exercise and ensure, that our shopping lists have ingredients that are healthy for us. We also need to prioritize our relationships, schedule that, Thursday night dinners, Thursday night, chess, with our old buddy, whatever it is, but kind of prioritize your relationships, schedule them if you need to. Consider throwing in new activities with people that, just to kind of spice up and strengthen that relationship. Maybe let's go do a movie together with someone that you've never gone to see movies with. So you really want to start off with strengthening what you've got. And if you would like to also establish new connections, it could be through kind of Mission MSA programs. It could be, participating in a group there, could be volunteering at some place in your community. And if there are barriers to connection, starting to confront those. Like I mentioned with loneliness, it can actually increase kind of wariness and distrust of others, in particular if we've been kind of chronically withdrawn and lonely, and it can lead to negative expectation in relationships like, oh, they don't want to talk to me. Oh, it's been so long. And so start to think about that. Well, is this actually true? What's the worst that could happen? Maybe kind of do a little bit of self-talk, try and change or modify some of that perspective. If there is depression, then consider meeting with a psychologist or a psychiatrist or talking to your neurologist, because depression can contribute to withdrawal, can contribute to a sense of loneliness. And so if there is depression, we do want to address that. Sometimes people may feel shame about certain motor symptoms, and so that may contribute to that, or there may be a sense of stigma, like people are going to be looking at me in public. And so I kind of maybe doing a little bit of self-talk and what matters. Do you care what strangers think? Is it more important to actually connect with that friend that you haven't seen, to have that coffee at the diner down the road? And just be creative and adapt to any changes in symptoms. It may be like, hey, I'm going to let you know at the beginning of our coffee, I might need to use the restroom a few times. And so just kind of adapt as needed, but confront those barriers because connection is important. There are a number of things that we can do, in the service of time. I don't want to belabor these, but you can invest time, reduce distractions when you are with people, but we'll make these slides available so that you can review each of these in detail. There are a number of strategies for kind of seeking things out and actively engaging and participating in groups that I've already alluded to. There are resources that the Surgeon General has put together as a part of his social connection initiative that has a social wellness toolkit. And one that I really like is this kind of social connection challenge where you kind of go through a few days and it's just like these different strategies that I talked about with strengthening former connections or trying new ones. What did you actually try out and how did that make you feel? So there are a number of approaches that people can consider and resources out there. But at the end of the day, to tie everything together, stress and mental health are common concerns for people living with MSA and their loved ones. So it's very important to foster resilience to manage some of that stress. And social connection in particular can be an especially potent way to kind of build resilience and community. And Mission MSA really can be a strong foundation for that via some of the support groups or online communities that they have through Mission MSA. But at this juncture, we'll thank you very much for your attention and we will open it up to any questions that individuals have.
All right, so thank you, Sarah and Dr. Gonzalez for the powerful session. So now we do have Sarah and Dr. Gonzalez now joining us live to answer your questions. So continue to please submit the questions through the Q&A box. We do have a lot of questions, so I'm going to start now. One question that we have in the chat, is there a checklist that can be used for all the end of life conversations? My people don't want to talk about it and I'm ready to talk.
Sure. One of the resources we shared, the Conversation Project, has different videos that talk about different aspects of end of life or wishes and preferences for care. And so you could watch those videos or review some of that on your own and start to think about it and introduce some of those with your family or friends or the people that you feel it would be important to know what your wishes and preferences are. You're right. I talk about this frequently, at least once a week with patients, and I'm a lot more comfortable, but the vast majority of people really don't want to have these conversations. And so it can be uncomfortable, but they're really important to start to have and think about, both for you, but also to be able to share with others. And then there's some legal documents that if you know what your wishes and preferences are, to start to complete some of those documents as well, so that even if family or friends aren't as engaged in this process as you are, that you can be taking steps for yourself. If you're someone living with MSA, to make sure that all of your affairs are in order.
Thank you. I have one question. Any advice for how to encourage a care partner to accept help? I'm trying to step in and help one parent to relieve my other parent, but they both brush it off even though I feel they need a break.
Yeah, often it can be really difficult to think about having someone in the house that you're not familiar with, or even thinking about what would that person help me do. We often get this comment in clinic as well. Okay, so I'm going to have a caregiver, and then what are they going to help me do? Are they just going to stare at me while they're sitting there for the 4 hours? Or why am I paying someone to just kind of sit there? So start to make a list, as you know, maybe as an adult child who's recognizing you'd like your family members to have more care. What are some things that a caregiver could help with? It can be as simple, or it could include things like changing the sheets, doing the laundry, running the vacuum, helping with meal preparation, or sitting with someone as they set up their medication to make sure that we're following the schedule correctly. So there's lots of different things, thinking about what you as a family have helped to step in to take on for your family members. Make a list of some of those things. You can make a schedule to say if a caregiver is coming for 4 hours on Monday and Wednesday, what are the tasks that that caregiver is going to help with? So that either going to your family members and saying, you know, I think it's really important that you have a break. I want you to make sure you're prioritizing getting to your appointments or spending time with your family, you know, friends, getting out to Bible study or your grandchildren's activities, and having a caregiver. Here's how the caregiver could help. And it would be as much a help to you as it would to me to know that you, mom, are getting a break, because I think it's really important. But it's not easy to sort of start to step back and recognize that it could be helpful to have some additional help.
Okay, thank you. And then another question, how often should advanced care planning documents be reviewed or updated?
They can be reviewed or updated. It's not something that you have to be looking at every 3 months or like every time you're going to the doctor. Often we may fill them out and then put them away and not look at them for a while. If there's a change in kind of how you're doing, if there's a new symptom with MSA that maybe is changing, your overall function, or may impact kind of what you are feeling like at this point, maybe I do or don't want a certain type of intervention. That might be a time to revisit your advanced care planning documents, or, you know, revisiting them with a provider and saying, here's how I filled these documents out 2 years ago. Here, you know, based on where we are today, and what I want, do these still reflect those wishes and preferences? So it can be beneficial to revisit them, but it's not something you need to be doing every visit.
Thank you. How should mental health symptoms be discussed with healthcare providers?
Can jump in. See, by simply, you know, raising it with them, and just sometimes even just preparing before a visit. So, because if you're meeting with a neurologist, for example, who's primarily focused on motor and autonomic symptoms, they may be kind of rushing through, maybe not rushing, but kind of focusing on certain questions, and you may feel a time pressure as they're going through. So sometimes even preparing before a visit, like, hey, I've actually been noticing I'm feeling sad, but it's not just a sadness that it's kind of like persisting. And I'm starting to withdraw. It's starting to result in me not wanting to do things even at home. So thinking, first noticing that and then saying that it's a priority. And so then going into a visit prepared, it's like, hey, I would like to talk to you about these things today. In addition to, you know, perhaps needing to use the restroom, I also want to talk about I'm feeling a little down. So coming in with a list like that can help make it easier to bring it up, but certainly bring it up.
Okay, thank you. How does palliative care address mental health in MSA patients?
Maybe Dr. Gonzalez and I can tag team this, but one way that palliative care can be helpful is another provider that's checking in around how your mood is in light of maybe how overall you're doing. And so the palliative care provider is often someone that may check in about depression or anxiety, starting to explore some of the symptoms or maybe putting together some symptoms that you're sharing. So it can be another opening to provide some education, to explore, and sometimes it can be really helpful to have some of those advanced care planning documents for someone who has maybe a little bit more anxiety about the future or uncertainty about what to expect. As we start to have some of those conversations, it can relieve some of that anticipatory anxiety, but you know, that may not completely resolve what's going on. And so that's where kind of Dr. Gonzalez and psychologists, neuropsychologists come into play and can be really valuable as part of your care team.
So often, yeah, palliative care is often a team-based approach that integrates multiple disciplines. And so in addition to helping, I mean, alleviating symptoms that can contribute to mental health distress, so palliation, helping kind of reduce the severity and easing um, some of these symptoms, that in and of itself can help with mental health. But if there still are questions, as one kind of thinks about like, there could be kind of, you know, depression and just kind of a sadness that persists, but it could even be very, rational questions that one has about one's meaning in life and purpose, and being able to talk with a trained professional that helps kind of reintegrate kind of your life and both cope with what's going on, think through some of the questions that you have in a way that helps you connect with your individual values, meaning, and the people that you love. Ultimately, all of those things, a particular mental health professional as a part of palliative care team can help with improving someone's mental health.
Thank you. And then here's like another question. Should palliative care be in person? I have two providers go to telehealth only models.
No, it doesn't need to necessarily be in person. I think access is the biggest consideration, and we know that as symptoms progress, getting out of the house and getting to appointments may become more challenging. So if you're connecting to a palliative care provider through telehealth, or you have a community palliative care provider, that's fantastic. It doesn't need to be in person.
Thank you. And then here's another question. How do I know if my loneliness is turning into depression or anxiety?
Yeah. So loneliness is it's simply a sense of like, the connections that I have are not what I would like them to be, whether it's kind of not enough and I'm feeling that restriction, or the ones that I do have aren't really meeting my needs. I don't really feel like I'm connecting with someone at an emotional level or a general support level, which you can feel down about when you think about that. But depression is a broader illness that involves like a sadness that can be more severe and more persistent. So it's not just kind of um, coming and going when you think about people, but it's just kind of sticking around. And when joy starts to get sapped out of things that you would typically want to do. So it's not just in the social realm, but you're finding you're withdrawing from just a number of different activities, or that they're bringing you less joy, are two core things. But then there's a whole host. You're noticing that your sleep is even more disrupted during this period of then increased sadness or lack of joy. You're feeling more tired. You're perhaps moving a little bit more slowly, or perhaps you're eating a lot more. Or then you're also just starting to think about not just how I miss people, but then I'm a bad person, or your thoughts start going in a negative place, what we would call negative cognitions, or thinking about not just connections, but about oneself, about the world, about the future. And that's really kind of when it's tipped over into a depression from just a quote unquote, like kind of just simple loneliness, which can be a complex experience.
Thank you. And then we have another question. Any tips for helping motivate our loved one who has MSA, example, exercising, getting up to move around, etc.?
Yeah, I can jump in for that one. There's no one fix that's going to work for everyone. A lot of that is actually knowing your loved one and kind of what motivates them, because we all have different motivators, and we all have different things that were a part of our lives. So sometimes it's just finding the right activity that fits with the person. Like they may say like, oh, a gym isn't for me, so then I no exercise. And it's like, even like gardening, if you're in a part of the country where you don't need to worry about 0-degree temperatures outside, then like being able to kind of like garden and doing that could be one activity. Using just bands at home and following the videos, sometimes that's enough to bridge the gap. So be creative about what activities are are being implemented. And even though MSA is different from Parkinson's, the Parkinson's Foundation also has a lot of really great exercise resources too that are applicable across groups. It's a good starting point to help with brainstorming. Sit and Be Fit is another that used to be through PBS that they still have archived online. It has a lot of exercise options that don't require a lot of mobility and going out. But also helping the person reframe on kind of why they might want to do it. Too. So have the person kind of self-generate reasons, like it's for my health, or even not just for health, but it allows me to connect with my kids, my grandkids, my cousin, with my close friend. And so having the person kind of think through why they might want to do it, as opposed to feeling like it's being forced on. So a lot of times with at MSA, we may feel like choice has been sat from us. I have this diagnosis, it's taking things away from me. So you can empower people, say, well, there's a lot that you still have control over. And so why might you want to do this? Here are some options on how we might do this. And focusing on an empowerment perspective that takes them into account can often help with then having an individual then engage with this.
Yeah, and if you're concerned that maybe apathy is playing a role in what is limiting motivation, sometimes it's creating a schedule and to say, here's the buffet of 8 things that I, as a care partner, would like for us to be able to do on any given day. But we're going to agree that there are 3 that we at least have to do each day. And from that buffet, you get to pick the 3, but we're going to do 3 today. That's just what we've agreed on. And so then again, to Dr. Gonzalez's point, you as someone living with MSA, you still have choice. You can decide what of those 8 things you're willing to do today, what feels good-ish. Nothing may feel good, but what feels doable. And when do you want to do them? Today I'm willing to take a shower, but I'm going to take a shower in the afternoon because I don't want to do that this morning. So we're still offering choice, we're still offering control, but we're also kind of creating a floor of like, this is the minimum acceptable of what we both agree is going to happen on any given day. And so that can be another strategy. Exercise or some of those other tasks can be part of that list of buffet of activities. But it can be something that's generated between the care partner and someone living with MSA, as both involved in that decision-making process as well.
Thank you. So we have lots of questions, but we're almost with the time. So I have one more question. Individuals like, thank you for the webinar and your support. I think my partner didn't accept my MSA disease. What can I do?
So the question is that the care partner is not accepting of the diagnosis.
Yes, and the patient's asking what can they do to help the care partner accept the diagnosis.
Yeah, I mean, first off, you can't control someone else. So sometimes even kind of raising kind of expectations there that, there are certain things that we ultimately don't have full control over someone else because they are not us. But certainly maybe communicating kind of why it's important, because I get a sense of that, of just like then feeling then like you don't have someone kind of on board to help you, to walk with you down this path. And journeys are better when you've got a co-pilot with you. So sharing kind of why it is that you like them on board, understanding why it is that they are not on board. Is it that they don't trust the doctor? Is it that they don't even know about this diagnosis? Is it that they just haven't actually read anything because they've been too busy? Is that they're so stressed that they're focused? So understanding kind of why it is that they're not on board, why it is that it's important to you. And then if they're not on board for certain reasons, like maybe come join the visit with me, with the doctor if you have questions, or like, hey, look at this MSA Spark talk, like, would you mind looking at it and we can talk about it over dinner, and like questions that you had afterwards. So that's kind of where my mind goes initially for that.
I also think, to kind of piggyback on that, sometimes we work really hard to continue to stay as independent as possible and do as much as we're able to do. And so Sometimes I hear from care partners that they're like, well, my loved one is fine. They're still able to do all of the things that they were able to do. But you, as an individual living with MSA, you may be working really hard, much harder than you used to have to be able to do those tasks. So it might also be kind of letting your partner in on some of the work that you're doing behind the scenes. You know, I get really tired. I'm getting up earlier because it's taking me much longer to get ready for work. Or I have to sit down now while I'm chopping the vegetables to make dinner because I can't stand up for that long. You know, so it can be this balance of trying to help let your care partner and family in to have a little more understanding of what you're going through, what day-to-day life looks like, while also kind of like Dr. Gonzalez is saying, it takes each one of us a different amount of time to start to wrap our head around what's going on and to adjust to what this new reality may look like and feel like. And it impacts each of us a little bit differently. But, you know, a lot of the strategies to slowly help, as you've helped work to adjust to it, your care partner will also need that time and space to adjust as well.
Alrighty. So thank you, Sarah and Dr. Gonzalez, for your presentation and asking the questions. And then I'll give it back to Casey.
Yeah, thanks again, Sarah and David.
Thank you.